This is week 3, the 4th week of human development to birth. The learning objectives for this week are to describe embryonic folding and organogenesis, to describe normal and maldevelopment of body cavities, mesenteries, diaphragm, and respiratory system, to describe the clinical presentation and treatment of a congenital diaphragmatic hernia, to describe normal and maldevelopment of the pharyngeal arches and grooves in the fetal face, including the eyes and ears and neck, to describe embryological development of cleft lip and/or palate, to list the teratogenic factors associated with clefts, to describe multifactorial inheritance and empiric risks of clefts to family members, to list syndromes associated with clefts, and to describe the treatment of cleft lip and/or cleft palate. Please use the embryology self-study, of which you have a link to as a review from your embryology course that you used before, and you can use the quizzes as guides to see whether or not you remember the material and as we proceed through this course. Today, despite the fact that there have been such great advances in neonatal care, a congenital diaphragmatic hernia is a moderately prevalent birth defect, and it is still a significant cause of infant death, and the surviving patients have significant morbidity. In looking at the clinical presentation of a congenital diaphragmatic hernia, it is a birth defect in which there is an abnormal opening in the diaphragm. The contents of the child's abdomen, including the stomach, intestines, liver, and spleen, may go through the hole and into his or her chest. This then prevents the normal development of the lung on that side and may also affect the growth of the other lung. It's important to remember that when the child's lungs don't fully develop, after birth, he or she will have trouble breathing. There are two types of congenital diaphragmatic hernias, a Bachdalic hernia and a Morgagni hernia. In the case of the Bachdalic hernia, it is a hole in the back of the diaphragm, posterior lateral defect. 98% of all CDHs are this type. In the case of the Morgagni hernia, it involves a hole in the front of the diaphragm, and a baby may or may not show any symptoms with this type of hernia. This occurs in about 2% and is an anterior medial defect. Let's look at the pathophysiology of CDH. When the organs from the abdomen prevent the lungs from growing, the poor lung growth is called pulmonary hypoplasia. Healthy lungs have millions of small alveoli, which are small air sacs, each of which resembles a balloon filled with air. However, with pulmonary hypoplasia, there are fewer alveoli than in a normal individual. The alveoli that are present are only able to partially fill with air. The alveoli deflate easily because of problems with a lubricating fluid called a surfactant. Normally, the surfactant, which is a phospholipid, decreases the surface tension, which allows the lungs to remain partially inflated. Now, when the air sacs deflate easily, the baby is unable to take in enough oxygen to stay healthy. In looking at a Bachdalic diaphragmatic hernia, each child may experience symptoms differently, but possible symptoms of a Bachdalic diaphragmatic hernia may include difficulty breathing, fast heart rate, cyanosis, abnormal chest development with one side being larger than the other, and having an abdomen that appears caved in. In looking at the complications of a Bachdalic diaphragmatic hernia, we find that babies that are born with this type of diaphragmatic hernia are more likely to have another birth defect, and in fact, almost 20% have a congenital heart defect. We also find that babies that are born with this congenital defect have chronic lung disease. This is a serious condition, and it can require the child to have oxygen or medications after being discharged from the hospital. Another complication is a gastroesophageal reflux. This is a condition in which acids and fluids from the stomach move up to the esophagus and can cause heartburn, vomiting, beating, or lung problems. It too can be controlled with medications and sometimes with surgery. Also see that some children have underdeveloped intestines. And if the child's intestines have moved into the chest cavity, they may also not develop properly, especially if they do not receive enough blood while they are developing. However, this is a very rare complication. Some of the other complications of CDH are babies have failure to thrive because children with the most serious lung problems are most likely to have growth problems because they often require more calories than a normal baby in order to grow and get healthier. And for those babies that have a gastroesophageal reflux, they also have feeding problems. As far as developmental delays, these include delays in the ability to roll over, sit, crawl, stand, or walk. And a baby with a CDH will almost always reach these milestones at an older age than most children. Therefore, physical therapy, speech, and occupational therapy can often help the child gain muscle strength and coordination. In looking at the long-term outlook for a child who is born with a CDH, these children are going to need long-term follow-up care, and they're going to require treatment from multidisciplinary teams of pediatric physicians, nurses, and other care providers. Please visit this video on CDH. About 80% of the individuals who are born with CDH, their cause is unknown, suggesting non-genetic, non-Mendelian, or multifactorial etiologies. Multifactorial inheritance and the possibility of epigenetic influence in CDH has been supported by monozygotic twin studies. There are, however, some chromosomal anomalies, copy number variants, aneuploidy that have been associated with CDH. The most prevalent for the aneuploidies is trisomy 18 because it is seen in 2.2 to 5% of the cases. In Down syndrome, where there are found to be patients that have CDH, it's most frequently with Morgagni hernias. Also, we find CDH with the Pallister-Killian syndrome, which I'm going to be talking about in the next few slides. I'd like to look at Pallister-Killian PKS, or mosaic tetrasomy 12p. This is one of the most widespread chromosome disorders associated with CDH. It's caused by a mosaic isochromosome which is on 12p. Now, if this sounds quite familiar to you, this is one of the little studies that I gave you in Genetics 600 last semester, where we were looking at an isochromosome. And if you go back and look at that, you'll see that people with tetrasomy 12p have alopecia, hair loss, mental retardation, seizures, extra nipples, defects in the diaphragm muscle, and slow movements. Most of the children do die as infants, but a few survive into adolescence. And if you were to do a karyotype, you would reveal that the affected individuals have an isochromosome that consists of material from the short arm of chromosome 12, but they only have it in some of their cells. So therefore, since the remainder of their cells are normal, we're looking at a mosaic. When you look at the mouths of these babies are said to have a long philtrum with a thin upper lip and a distinct cupid bow. And if you look at those pictures, which are in Smith's Recognizable Patterns of Human Malformation, which you can look at on page 282 to 285, you can see some pictures of children who have it. And I will follow this slide with another slide that does have a picture of a child that has the PKS. What you need to remember is that 50% of individuals that are born with PKS have CDH. And so I want to then now look at the next picture, which will show you a child that has the disease. So here is a baby with PKS. One of the things to note about her is she has that cupid bow mouth. She also has a long philtrum. If you look at the and has sparse anterior scalp hair, and if you were to look closely, she has epicanthal folds. Some of the other features of this syndrome are not you're not able to see by just looking at this picture, but her face is looks very much like the average child that does have the PKS syndrome. Please watch this video on a child who was born with CDH. Cleft lips and cleft palates are usually divided into two groups. The isolated cleft palate is one group, and the other group is the cleft lip with or without the cleft palate, representing a heterogeneous group of disorders affecting the lips and oral cavity. When the embryo is in weeks 5 through 6, the tissue that will become the upper lip is supposed to meet and fuse. At about 7 weeks, the tissue that will become the palate should also meet and fuse. However, if growth is inhibited, a gap or cleft results. Children with a cleft lip with or without a cleft palate or a cleft palate alone often have problems with feeding and speaking clearly. They can also have ear infections and hearing problems. And they also have problems with their teeth. Please review the videos on the development of the cleft lip and cleft palate. A cleft lip with or without a cleft palate is a relatively common anomaly associated with more than 400 different syndromes. For example, Stickler syndrome, 22q deletion syndrome, van der Waals syndrome, and Pateau syndrome. In 1965, Gunnar B. Strickler studied and described this condition, which is also known as hereditary progressive orthoopinopathy, and it is an autosomal dominant disease. It's thought to arise from mutation of several collagen genes during fetal development. Now, the characteristic feature of Stickler syndrome is a somewhat flattened facial appearance caused by underdeveloped bones in the middle of the face, including the cheekbones and bridge of the nose. Individuals with Stickler syndrome also have ocular problems, hearing loss, and joint problems, which tend to lessen with age and normal growth. The cleft palate abnormalities can be treated with routine surgery. And these signs and symptoms of individuals with Stickler syndrome vary widely among those affected. You can see this disorder on pages 378 to 381 in Smith's Recognizable Patterns of Human Malformation. Here are some pictures of some individuals that have Stickler syndrome. In looking at some of the other abnormalities in Stickler syndrome, these include arthritis, abnormality in the epiphyses of the bones, vertebral abnormalities, scoliosis, joint pain, double jointedness, which is hypermobility, are all problems that can occur in the bones and joints. And learning difficulties can also occur because of hearing and sight impairment. And also, there are some children that have mitral valve prolapse. A particular group of physical features called the Pierre-Robin sequence is common in children with a Stickler syndrome. And this sequence includes a U-shaped or sometimes V-shaped cleft palate with a tongue that is too large for the space that is formed by the small lower jaw. Please go to pages 314 to 315 in Smith's Recognizable Patterns of Human Malformation, and you can read about the Pierre-Robin sequence. Here you can see the Pierre-Robin sequence or syndrome features with the cleft palate, the large tongue, and the small jaw. Here is a child with Pierre-Robin. And here is another child with Pierre-Robin. In looking at van der Waals syndrome, it was discovered in 1954 by van der Waals, and it is an autosomal dominant disorder. It's the most common syndrome associated with cleft lip or cleft palate, and we also see that not only the cleft lip and or cleft palate are present in these individuals, but they may also have depressions, pits near the center of their lower lip. This happens in about 80% of those individuals with this syndrome. And these pits may appear moist due to the presence of salivary and mucus glands in the pits. There are also small mounds of tissue on the lower lip that can occur, and some have missing teeth. Growth and intelligence are usually normal. It's caused by mutations in the IRF6 gene, and you can go to pages 318 to 319 in Smith's Recognizable Patterns of Human Malformation to see this disorder. And this is a picture of a child who has the van der Waals syndrome, and you can see those lip pits in this picture here. In addition to the genetic causes for cleft lips and cleft palates, they may be caused by environmental factors related to the lifestyle of the pregnant women. For example, a diet low in vitamin B, or a diet that's low in folic acid, drinking alcohol, smoking cigarettes, rubella, thalidomide, and anticonvulsant drugs. The long-term effects of cleft lip and or cleft palate are effects on speech, hearing, appearance, and psychology, can lead to long-lasting adverse outcomes for health and social integration. Typically, children with these disorders need multidisciplinary care from birth to adulthood and have higher morbidity and mortality throughout life than do unaffected individuals. Cleft lips and or cleft palates are inherited as a multifactorial disorder when they are not associated with a specific syndrome. And it's a complex inheritance for reasons that are not well understood. To predict the chance that a polygenic multifactorial trait will occur in a particular individual, you use empiric risk, which is based on the incidence in a specific population. A cleft lip with or without a cleft palate occurs 1.4 per 1,000 newborns worldwide. The frequency varies widely among ethnic groups, and the highest prevalence is in Asians and Native Americans. Also, 60 to 80% of newborns that have a cleft lip, cleft palate, are males. The clefts vary from incomplete cleft lip to those that extend onto the nose and the alveolar part of the axilla, and the cleft lip may be unilateral or bilateral. A cleft lip is more likely if a person has a relative with the condition, and the risk for the cleft lip palate in a child increases as a function of the number of relatives that the child has who are affected, and the more closely related they are to the child. The more severe the defect, the higher the risk of recurrence for future siblings. Now, the risk that one would give in the general population with no affected relatives is a 0.1% risk. With one sibling, 3%, with one parent, 3%, and with two siblings, 8%.